Hi everyone, welcome to NURS 5030 Nursing Professional Practice 1. This session looks at patient assessment, nursing and health settings. Before we begin, just be aware of curtain copyright and any processes that you might need to be aware of. In this capture, it's a relatively short capture and designed to gather your preparations for health assessment and ensure that you start to have baseline knowledge and practice so that when we do our laboratories and then simulations, you start to put in place all those different requirements of health assessment. So we're going to examine the nursing process, registered nurse standards for practice. We're going to explore the different types and frameworks of assessment, health assessment, and what each different assessment framework actually includes. And we're going to examine communication skills during assessment and then of course documentation skills. So nursing assessment is actually really important. This is actually done when you first meet the patient and you start gathering that history from them, and sometimes it doesn't matter how small the data or how seemingly insignificant it might be. It is all very important that it's actually collected in a systematic way and documented in a systematic way. Now, our reason for actually being systematic in the ways we collect data and the way we report data is that it actually is important in terms of giving us a really good status or update of where the patient's health condition is at the time. Excuse me. Assessment is the foundation of the nursing process and promotes critical thinking, and it's that critical thinking of why is this data important to the to the person's health outcomes. Or often, sometimes you also need to provide an explanation of why you need particular data. So the why component is important in terms of you being sure why you're gathering particular data and how it's going to inform the patient's medical history and then serve to generate a care plan that's actually going to be personalised and appropriate to what that person's health condition is. An accurate assessment leads to appropriate diagnoses and interventions and safe patient outcomes. So when we look at the RN standards for practice, standards 1, 2 and 3 absolutely apply, but what I want to do is actually show you in standard 4 that you are comprehensively conducting assessments, so it's part of standard 4. It's part of standard 5 because you are developing a plan for nursing practice, that is patient care. Standard 6 is about ensuring the safe provision of appropriate and responsive quality nursing practice, and Standard 7 evaluates outcomes to inform nursing practice. So this all stems from your assessment data in terms of how you're working with your people. And also, bearing in mind that you are gathering and often providing care for more than one person. Now, there are a variety of nursing assessments or types of nursing assessments done, and that is an initial or an admission assessment, and what this does is provide a comprehensive baseline of that patient's history, social, psychosocial, medical and surgical history and family history, and so often we gather this information on admission to hospital, on admission to care, on admission to whatever procedure they might be needing. The second type of a nursing assessment that's done is a focused assessment. Then we have time-bound assessments and of course emergency assessments. So when we are gathering the components of a complete assessment, so we're going to think about gathering a comprehensive assessment because this would be important for you, leading so that you've got thinking about admitting people to hospital or to healthcare or that type of scenario. So when we're looking at the components of a complete assessment or a comprehensive assessment, there's always health history. We then confirm that health history with a physical assessment, data collection. We then confirm and write our documentation standards, and we look at communication skills during assessment as well. So the components of a complete assessment is always building, so the health history is always then being confirmed with a physical assessment or the objective data collection that actually occurs. And then documentation standards is how we document what needs to be done or what is gathered, and then what type of communication skills did we use during that assessment to gather the right information from all the people we need to. So when we think about the types of nursing assessments, for example, a focused assessment, this is an initial or admission assessment, and what it does is establishes baseline data for future comparisons and comprehensive care planning, and it's usually performed within a specified time frame after admission, so typically between 8 to 24 hours depending on the facility's policy. But what it does is look at it's a comprehensive head-to-toe assessment plus a detailed health history, and so often what we're doing is we're looking at that complete health history, which includes medical history, surgical history, family history, current medications and allergies, review of all body systems, psychosocial assessment, functional assessment, and then risk assessments. And those risk assessments are going to be detailed in terms of what that person needs. So when we look at, let's say, a focused assessment, focused assessment, this is where we're targeting specific body systems related to the patient's chief complaint or their condition, and they're performed as needed because they're based on the person's condition or concerns. So, for example, we would be doing a respiratory assessment for a patient with pneumonia, we'd be doing a neurological assessment for a patient with altered cognition, or we might do a cardiovascular assessment for a patient with chest pain. So the benefit of actually using a focused assessment is that it's an efficient use of time when full assessments are not indicated. When we look at time-bound assessments, for example, these are shift assessments, and these are performed at the beginning of each nursing shift. They're often less comprehensive than initial assessment. It focuses on pertinent findings and changes from the previous assessment. So, for example, we might look at post-procedure assessments conducted after interventions. We're monitoring for complications. We're evaluating the effectiveness of treatments. And a prime example here is a post-operative assessment that focuses on incision levels, pain levels and vital signs, because we're assessing for the risk of hemorrhage following a surgical incision. Or if we were looking at scheduled assessments, these are regular intervals for specific conditions, and it might be that we're doing hourly neurological assessments for a traumatic brain injury, or we might be doing 15-minutely checks for unstable patients. So you can see that depending on what's happening with the person as to what approach you're actually going to be taking. And lastly, we're looking at emergency assessments. Now, the emergency assessments are a rapid evaluation of life-threatening conditions and often follows an ABCDE framework. And this is a really good framework to actually get comfortable with, because we're looking at the airway breathing, circulation, disability and exposures. Very important. So the characteristics are brief but focused on critical parameters. It prioritises immediate life threats. We're going to do an ongoing reassessment as interventions occur, and we've got documentation considerations that sometimes documents, some of the considerations are documented retrospectively once we've got stabilisation occur. So in the example of, let's say, a code blue, for example, in days gone by, it was a retrospective documentation process, but now with Code Blues, we actually find that documentation actually happens concurrently. So when you do your emergency life support in semester 2, you'll find that you will explore the roles, the different roles in a medical emergency process quite differently. Okay, so the assessment frameworks that we're going to break down a little bit. This is a head-to-toe systemic approach. So you can imagine it's head and it's to your toes. So it's encompassing all of the body, but we're doing it sequentially from head to toe. It's also known as a cephalocaudal approach. Cephalo being head and caudal being bottom part. We also then have body systems approach, Gordon's functional health patterns approach, and activities of daily living. So now it's going to depend on the context that you're working in as to which assessment framework is used by that setting. So the if I could, just before we get into the details of each of those frameworks, what I wanted to do was just talk generally around some of the very components that are relative to each approach that you're using. It's just what changes is how you gather the data, the sequence in which you are gathering data. So when we're looking at health history gathering, for example, health history is tell me about what has happened to your health in the last 12 months. Or can you tell me about your medical or surgical interventions since blah, blah, blah. So communication techniques are open-ended versus closed questions. We're using active listening skills, and what we do is build rapport while we're being efficient. So that is, we learn to relate to people and gather very important data quickly. Now, the key components to collect in a complete assessment is the chief complaint and your history of presenting illness. So what is it that brought you here today? Okay, and then so that's an open process that you're doing, and then your past medical history and surgeries, your family history of relevant conditions, your social history such as your occupation, your living situation, any support systems, health behaviours such as smoking, alcohol, exercise or diet, medication history, do you take prescribed medications, over-the-counter medications, supplements, and do you take all of your prescribed medications or not? So, and then allergies and reactions. So special considerations that we need to take account of is that there are cultural influences on health perception, and so as you gather information and work with people from different cultural groups, you'll understand the differences in how they relate health being influenced by their culture. The other component is health literacy, because health literacy may not be as well understood as in individuals, and sometimes it's also around English language comprehension, and so we need to use interpreters effectively. So if we're gathering specific health literacy assessments, we need to, and a person has got poor English or their English is not so robust, using interpreters is absolutely important, because what we want to do is be assured of the information that we are gathering as it's going to actually impact the type of care that will be required for that person. Now, when we look at physical assessment techniques, so this is we're now confirming the type of data that we have gathered from that person. We're confirming what they've told us, and that depending on the system or the focused assessment that you're doing as to how much of an exploration you're going to need to do. So physical assessment techniques actually require preparation. So where is the equipment we are gathering? We need to practice hand hygiene and infection control. We need to look at patient positioning and draping for privacy, and we also need to be able to explain to people the procedures that we're going to be undertaking. And often the explanation of what we're doing, it also includes the why we're doing it. In terms of examination methods, we use the IPPA format, and so inspection, that's the I. It's the visual examination of what that system we're looking at. So it might be around colour, symmetry, lesion. Palpation includes light and deep palpation techniques. We're looking for tenderness, and we may be palpating for masses. Percussion is a direct and indirect method, and we use sound interpretation to help guide what we are finding. And then auscultation is the proper use of the stethoscope to give us normal or abnormal sounds. So do not underestimate the power of inspection. Palpation you are probably familiar with already, let's say in terms of breast assessment. When we think about breast cancer risk, one of the advocates' methods of assessing for masses is to do BSE, or breast self-examination, for example, and that uses palpation techniques. Percussion we use less on ourselves, and auscultation is something that you will begin to love. So when we're looking at specific systems assessment, and this is each week you're going to be exploring something further, is that you will you'll be doing cardiovascular. So for example, heart sounds, pulses, capillary refill. Respiratory assessment may look at breath sounds or respiratory effort and chest expansion. A neurological assessment tells us about levels of consciousness, pupillary responses and strength testing. Gastrointestinal assessment tells us about bowel sounds, abdominal assessment, output assessment. Musculoskeletal assessment tells us about a person's range of motion, their strength, their gait. And a skin assessment or integumentary assessment gives us a skin assessment as well as a wound assessment. So you'll find that when we're doing system assessments, we're actually gathering specific data that's going to tell us about that system. But remember that even if we're gathering specific physical data, we've already asked that person about, do you have any, we've gathered that subjective history, do you have any problems with cardiovascular effort, have you had any MIs, etc., etc. So then when we think about documentation standards, we're really looking at the principles of effective documentation. And so objective data is the data that we gather through our physical assessment techniques, and subjective data is what that person has told us. And so what that person has told us is always confirmed by what we found. When we're looking at effective documentation, we're ensuring that what we've documented is factual, accurate, complete, and documented in a timely way. And what we want to do is avoid bias and judgmental language. Sometimes the documentation formats that we use is narrative charting, problem-orientated medical records, a little bit like the file that we're using in our class, flow sheets and checklists. And when you're in the clinical area, you'll actually see that some of the health settings actually have electronic health records, and therefore that is what you contribute to electronically, which is almost similar to what you would do longhand in the written format. whether it's electronic or written, there's always a legal implication in terms of documentation. So if it's not documented, it's not done. That's generally the principle we apply, and documentation is always legal evidence, and so therefore we want to make sure that we report our records in a legal fashion. And then of course, if we make an error, it's how do we document those corrections of errors in documentation. So we'll do a little bit more around that when we do our tutorial number 4. Okay, so when we're thinking about communication skills during assessment, therapeutic communication techniques are around establishing trust, cultural sensitivity, we're ensuring that it's age-appropriate communication, and we're communicating with patients or people who have special needs, and those special needs might be across the lifespan. We also have an interprofessional communication approach that we use, and so we use ISABAR or SBAR formats for reporting findings. We also have a chain of command for critical findings or interventions required, such as in our AORC chart, and we also consult with other providers in relation to assessment data. So it might be around referral processes or consultation processes required. And then of course we've got family communication as well, and that's involvement in assessment processes, any privacy considerations or any health education required during that assessment. So the assessment frameworks that we're looking at, and this is a head-to-toe systematic approach. Remember I said this was also a cephalocaudal approach, because cephalo being head and caudal being bottom. Okay, but we're actually moving to below the bottom. So there's a certainly what we're doing is that we start with general appearance and vital signs, and then we move systematically from the head downward. And what this approach is beneficial is that it's comprehensive, and you're less likely to miss findings. So there's a detailed sequence around general appearance, their level of consciousness, vital sign assessment and interpretation, your skin assessment, and that looks at colour, temperature, turgor and integrity. Head and neck assessment looks at the cranial nerves, lymph node, thyroid, for example. Eyes, ears, nose and throat assessment, respiratory assessment, cardiovascular assessment, abdo assessment, musculoskeletal and extremity assessment, neurological assessment, motor sensory and reflexes, and genitourinary assessment. So you can see that the approach head to toe is actually very organised and very sequential, and that is one of the advantages of using this approach, because just as you use it, you can actually document information that same way. Okay, so when we're looking at a body systems approach, this is organisation by physiological parameters. And so this is our body system, so cardiovascular system, respiratory system, neurological system, genitourinary system, musculoskeletal system, integumentary system, and the endocrine system. So what this does is allows focus on systems relevant to that chief complaint and facilitates a comparison of related findings. And often what this system does is actually works with a biomedical model of assessment, and you'll find that often it's an approach that's used in, let's say, acute sectors, or let's say in ICU, for example, where we need to know what's happening physiologically at each system level. So what it does is integrates subjective and objective data by system. In comparison, when we look at assessment frameworks, we've got the Gordon's functional health pattern, and here we've got functional health patterns such as health perception, health management, nutrition, metabolic, elimination, activity, exercise, sleep, rest, cognition, perceptual, self-perception, self-concept, roles and relationship, sexuality and reproductive, coping and stress tolerance, and value belief. So these, in the functional health pattern approach, the body systems are embedded within each of those relevant areas. So for example, activity and exercise health pattern includes cardiovascular, respiratory, musculoskeletal and neurological perception. So you can see that there are systems that are also explored within that health pattern, but it gives you a broader frame because you start to understand, well, what are the physical or psychosocial aspects that this person needs to be able to care independently for themselves. So it's a holistic approach. It's a focus on function rather than medical diagnoses, and facilitates nursing diagnostic formulation. And often the assessment questions are specific to each pattern, and your documentation framework is based on that pattern. So often the the Gordon's Functional Health Pattern framework is used in residential care as a really good way of understanding what's happening to this person. And the last one that we have is the activities of daily living framework. And this one here is that we're looking at basic ADL assessment, bathing, dressing, toileting, transferring, continence, feeding of themselves, or instrumental activities of daily living. So medication management, finances, transportation, housekeeping. And so often with this type of an assessment is that because we're looking to see the level of independence to dependence, or complex activities required for independent community living, or the ability to independently care for oneself in those basic ADLs, for example, is that there are a number of different assessment tools that can be used. So it's the CATS Index of Independence, the Lawton-Brody IADL scale, and the Barthel Index. So you've got to think around those assessment tools. They are used to give you information about your basic ADLs and instrumental ADLs that may be required for this person. And this again is a common one when people are transitioning from community to care to permanent care, such as residential care, or if they were previously independent but had a massive, let's say, motor vehicle accident, and they were rendered non-independent, then that level of assessment and community support required needs to be identified. So the benefits of this is that it's patient-centred, it focuses on functional abilities, there are clear indicators for discharge planning, and identifies specific areas of needing assistance, and there's a connection to care planning and support service needs. And then the other thing you need to be aware of is there are special considerations. Now, cultural sensitivity is implied in all of the assessments. It doesn't matter which framework you're doing. Cultural sensitivity applies to all frameworks and all assessment strategies that are used, and age-specific considerations might also need to be applied, such as pediatric or geriatric. Mental health assessments we're not exploring here because you're going to do a whole unit on mental health assessment. And then of course pain assessment, that's a specific category that we work through as well. So what I would like you to do is to perhaps practice each of those different methods of actually doing a health assessment, and I want you to bring those examples to class, to the first laboratory and first tutorials, so that you can start building on your practice repertoires. You will be practicing interviewing and gathering data during laboratories and the simulation in preparation for clinical practice. And what we do is we compile de-identified written records to develop your skills. So that's what we do with our patient folder. So we're going to use those in the labs as well as in the simulations. So I look forward to working with you in our labs, in tutorial, and then later on in the simulation. Thanks everyone.